Hello, my name is Nicholas Wyatt. Today we're going to talk about challenging cases in asthma assessment and treatment for the primary care provider. The first case that we'll discuss is going to talk about the pathophysiology. So, let us begin. Upon completion of this topic, the participant will be able to 1. Describe asthma pathophysiology, including risk, innate vulnerability, genetic predisposition, and impact. The participant will also be able to describe small airways and laminar airflow and discuss the significance of small airway obstruction and structural alterations in small airways associated with severe asthma. So let's talk about the case. So the first case for asthma physiology is BW is a 5-year-old biracial female with a history of shortness of breath. Her episodes are more frequent during the spring season and shortly after increased physical activity. She's not currently being seen by a pediatrician, but her parents do take her to the emergency room approximately every other month. Her mother states that she has been prescribed an inhaler in the past, but does not remember the name of the medication. So when we start talking about asthma, it's important to know kind of a history behind asthma. Asthmenio, a Greek word indicating panting or gasping, was first used by the Greek physician Hippocrates to describe asthma. Since the days of Hippocrates, methodological advances have changed understanding of asthma etiology, associated treatment modalities, and how asthma is defined. The National Asthma Education and Prevention Program, NAEPP, defines asthma as a common chronic disorder of the airways that involves a complex interaction of recurring symptoms, airflow obstruction, bronchial hyperresponsiveness, and an underlying inflammation. Regardless of how asthma is defined, the disease currently affects 300 million people worldwide, with 22 million being citizens of the United States. In the past decade, the proportion of asthmatics in the United States grew by nearly 15%. Currently, asthma affects approximately 7.5% of the American population, or 22 million asthmatic patients. Age, gender, and or race can play a role in the patient's risk of having asthma. About 2/3 of the asthmatics are adults, with adults ages 18 to 24 years being more likely to have asthma than older adults. Although only 1/3 of asthmatics are children, 80% of the total asthmatic population begin to show symptoms during childhood. In childhood, men are more likely than women to have asthma. However, in adulthood, it is reversed, and women are more likely than men to have asthma. Why is that? One proposed explanation is the gender differences in airway development and lung anatomy. Studies have shown that the airway of prepubertal males are smaller than prepubertal females. However, during the airways of males undergo more pronounced growth and development, resulting in airway volumes that are equal to or greater than those airways of females. Thus, smaller airways are more likely to develop airflow limitation that leads to symptoms of asthma. Let's take a look at ethnicity. Looking at ethnicity, black adults are at a slightly higher likelihood of having asthma than white adults. But black children are 2 times more likely to have asthma than children. But what do all these numbers mean? What is the health and economic impact of asthma in the United States? Well, we'll discuss that on the next slide here. Knowing that 1 in 11 children and 1 in 12 adults have asthma reveals the real impact asthma has on health in the United States. Asthma exacerbation accounts for approximately 15 million missed work and school days annually. About 1.75 million emergency room visits annually will be due to asthma exacerbations, accounting for 25% of all ER visits. 20% of the patients visiting the ER will require hospital admissions, where the average length of stay is 0.3 days. In 2009, asthma exacerbations accounted for the death of nearly 3,500 people. So asthma is a serious health concern in the United States, but what about the associated economic concern? Asthma is an $18 billion disease. That's right, $18 billion. and is becoming an increasingly more expensive disease in the United States. So how can the cost of asthma be controlled? In order to answer that question, let's look at the direct and indirect cost. The $10 billion direct cost of asthma includes costs associated with medication, outpatient visits, ER visits, and hospitalizations. Medications account for greater than 50% of the direct costs associated with asthma. But interestingly enough, research has shown that there is little difference in medication cost in patients with or without exacerbation. The $8 billion in indirect costs of asthma includes costs associated with missed or less productive school or work days. So, controlling the cost of asthma starts with controlling the direct cost, specifically controlling the cost of outpatient visits, ER visits, and hospitalizations related to exacerbations. Control of these costs starts with successful asthma management. Successful asthma management includes controlling of environmental factors and comorbid conditions that affect asthma, assessment and monitoring, pharmacologic therapy, and education for a partnership in asthma care. Let us start our discussion with controlling environmental factors and comorbid conditions. Successful asthma management starts with controlling exposure to asthma triggers. Since complete elimination to asthma triggers is not always possible nor desirable, knowing how to manage asthma when exposure occurs is equally as important. For example, 90% of asthmatic patients develop symptoms of asthma when they are exposed to increased activity. Increased activity is desirable for optimal health. Therefore, management of asthma to the exposure of the trigger is more desirable than elimination of the trigger. Smoking is similar but different. 60% of asthmatic patients exposed to smoke develop symptoms of asthma. Elimination of smoke is desirable for optimal health, but the patient cannot control all exposures to all sources of smoke. So, although in this case elimination to the trigger is desirable, it is not always possible, making again management of asthma to the exposure an important component of controlling the symptoms of asthma. The exposure of the asthmatic patient to a trigger leads to a cascade of events that are responsible for the clinical manifestations of asthma. Prior to discussing the pathophysiology of asthma, it is necessary for us to review the development, structure, and physiology of a normal lung. Lung development occurs in a series of 3 periods, with 5 defined stages. The embryonic stage begins approximately 3 weeks after fertilization and is complete 6 to 7 weeks gestation. During the embryonic stage, lung sacs develop from the ventral wall of the esophagus, and the major airways and lobes are formed by a series of budding. Starting at approximately 7 weeks gestation, the pseudoglandular stage begins. During the pseudoglandular stage, the bronchial tree develops and buds to form the bronchi, bronchioles, and terminal bronchioles. The next stage, the canicular stage, begins at approximately 17 weeks gestation. During the canicular stage, lumens begin to form in the bronchial tree. Vascularization arranges into sleeves around the bronchioles, and the epithelium differentiates into type 1 and type 2 nematocytes. At about 27 weeks gestation, the saccular phase begins, which leads to the formation of alveolar ducts and air sacs development, concluding the fetal period of lung development. A term baby experiences a rapid rate of lung development in the first year of life. The lung volume will double during the first 6 months of a life and triple within the first year. Now that we have an understanding of normal lung development, let us discuss the pathophysiology of asthma. Asthma involves a complex inflammatory process largely driven by IgE-dependent mechanisms. The inflammatory process starts when allergens or asthma triggers adhere to inflammatory cells and/or structural cells. These cells synthesize and release a variety of mediators which trigger an acute and/or chronic effect. The details of asthma pathogenesis are discussed on the following slide. The acute inflammatory process starts with the activation of inflammatory cells, principally mast cells and eosinophils. These inflammatory cells synthesize and produce acute-acting inflammatory mediators, specifically leukotrienes, prostaglandins, and histamine. The inflammatory mediators rapidly induce smooth muscle contraction, mucus hypersecretion, and vasodilation with endothelial leakage and local edema formation. These mediators also possess chemotactic activity, recruiting additional inflammatory cells such as eosinophils and neutrophils to airway mucosa. Structural cells, specifically epithelial cells, also appear to be involved in the inflammatory process. These cells release leukotrienes, prostaglandins, and inflammatory cytokines on activation. These acute events are followed by the recruitment, multiplication, and activation of immune inflammatory cells as a result of locally released cytokines and chemokines. These mediators trigger a series of events that include promoting growth of mast cells and eosinophils, influx and proliferation of T lymphocytes, and differentiation of B lymphocytes. These events result in local airway inflammation and airway hyperresponsiveness. So how does a non-asthmatic airway compare to an asthmatic airway? Well, let's take a look. Like they say, a picture is worth 1,000 words. As we can see, an asthmatic airway can undergo significant airway remodeling. This is a Mauvat's pentachrome stain of medium-sized airways from a normal and severe asthmatic patient. Severe asthmatics will often have significant narrowing of the lumen. The epithelium of asthmatics often show mucus hypersecretion with significant basement membrane thickening. The smooth muscle volume is increased in asthmatics owing to a combination of smooth muscle hypertrophy and hyperplasia. All of these airway remodeling changes have varying degrees of impact on lung volumes and capacities. The air within the lung at the end of a forced inspiration is divided into 4 lung volumes. The tidal volume, also known as VT, is the volume of air exhaled during normal quiet breathing. The inspiratory reserve volume, also known as IRV, is the maximum volume of air inhaled above tidal volume. The expiratory reserve volume, also known as ERV, is the maximum volume of air exhaled below tidal volume. The residual volume, also known as RV, is the amount of air remaining in the lungs after a maximal exhalation. The combinations of 2 or more lung volumes are termed capacities. The functional residual capacity, also known as FRC, is the volume of air remaining in the lungs at the end of a quiet expiration and is the sum of the RV and the ERV. The inspiratory capacity, also known as IC, is the maximum volume of air that can be inhaled from the end of a quiet expiration and is the sum of the VT and the IRV. The vital capacity, also known as VC, is the maximum amount of air that can be exhaled after a maximal inspiration. It is equal to the sum of the IRV, VT, and the ERV, and is also approximately 75% of the total lung capacity, which is also known as the TLC. Now, the VC can have different meanings based on measurement. For example, when measured over an exhalation of at least 30 seconds, the VC is called the slow vital capacity, also known as the SVC. When measured on forced expiration, it is called the forced vital capacity, also known as the FVC. FVC can be expressed as a series of time volumes as well as flows. The forced expiratory volume in the first second of expiration, also known as the FEV1, is the volume of air exhaled during the first second of the FVC maneuver. The peak expiratory flow, also known as PEF, is the maximum flow obtained during the FVC maneuver. How do these volumes and capacities change with respect to the asthmatic patient? Well, let's take a look. The first abnormality likely to be observed in an asthmatic patient is a slightly increased residual volume with a slightly reduced expiratory reserve volume. Why does this occur? Well, these changes are due in large part to the air trapping that occurs with airflow limitation. So, how does air trapping occur? Well, let us take a look. As you know, airways are essentially flexible tubes in a box of air, the thoracic cavity. During tidal breathing, at the end of expiration, the pressure within the thoracic cavity is 0. This results in no pressure gradient between the alveolus and the atmosphere, i.e., air is not moving into the lungs and air is not moving out of the lungs. Expiration occurs when respiratory muscles contract and increase the pressure both within the thoracic and within the airways. When the respiratory muscles contract, the pleural pressure exerts a positive pressure on the outside of the alveolus and airways. This causes air to be pushed out of the alveolus and down the airway. As air is traveling down the airway, the pressure drops because energy is lost due to resistance of the airway and increased velocity. However, the pressure in the thoracic cavity remains constant. At some point, the pressure outside the airway equals the pressure inside the airway. This is known as the equal pressure point. Beyond the equal pressure point, the airways will narrow, leading to airflow limitation and air trapping. Now that we have a better understanding of how air trapping occurs, let us take another look at the volume and capacity comparison slide. Earlier, we discussed that two of the early abnormalities in mild asthmatics were an increase in residual volume and a decrease in expiratory reserve volume. In patients with severe asthma, a further increase in residual volume, an increase in expiratory reserve volume, and a decrease in inspiratory reserve volume occurs. So how do these changes in RV, ERV, and IRV affect the lung capacities? These volume changes lead to a rise in the functional reserve capacity and total lung capacity. Why do these changes occur? Again, it's largely due to air trapping from more severe airflow limitation. Now, let us revisit our case to test our knowledge.